off. Welcome to another Saturday morning in our health hour, and thanks for joining us. And as usual, as you know, we have a number of things that pertain to health matters, and today we're going to be talking about mental health, but specifically on perinatal mental health. I think the whole pandemic issue has raised the fact that it's very easy to feel isolated and have problems with our mental health in general. But I think it's an even worse time for mothers. It can be a more challenging time when you're worrying about all the things to do with your pregnancy, and are led upon that are the decisions they're asking people to make about vaccines within the COVID era. You're pregnant and you're worried about things. So having this talk today about perinatal mental health and mental health for mothers is, I think, a really important topic. So Dr. Maame Sarfo is joining us, and she's a psychiatrist who works at Avon and Wiltshire Perinatal Mental Health Trust, which is down south for those of you that don't know. And she's going to just have a general chat with us about some of the issues that pertain to this. As usual, you're welcome to ask questions. You can either do that directly by raising your hand at the end of her talk. This is really rather informal today, so if you want to ask questions in between while she's talking, if she raises anything you want to have clarification for, please do. You can also, I find that sometimes people want to raise questions about their own personal health issues, so don't want to put that in the chat themselves, but you can send me a private message and I'll raise the question on your behalf. So without much further ado, I'll introduce you to Dr. Maame to start her talk. And thank you so much for coming today.
Thank you. Thank you very much, Dr. Ngozi. Just a point of correction. I am a general adult consultant psychiatrist. I'm not a perinatal specialist, but I do have special interest in perinatal, and obviously mental health is my specialty. So I was just thinking of just going through the thoughts for today, just to offer some statistics as to how relevant or how pertinent perinatal mental health is, and specifically mention some specific mental health issues. I would mention the commonest presentations that people are aware of, and people, as Dr. Ngozi has said, people can ask questions as they go along. I also will be looking at management in general, or what we doctors look at as to how to support people, and we call something like psychosocial management. That's looking at psychological interventions and social interventions that would matter. And ultimately, being a doctor, I would have to touch a bit around medication use in perinatal psychiatry. I want to talk about perinatal psychiatry. It's generally referring to the stages from pregnancy to 9 months. That is when you have those specialist inputs. So to start with, I think these statistics matter. There is a condition that some people might know is called bipolar affective disorder, and it obviously affects the general population. But when you come to perinatal, mothers who are pregnant or mothers who've just had babies, the rate of relapse is twice as compared to the general population. So which makes it quite relevant that if we, as women, or being pregnant or having a baby, you are twice as at risk of relapse, and then makes it relevant to keep that in mind when you have a relative or somebody who has a diagnosis. Depression, most women who suffer with depression, from moderate to severe depression, have a 68% chance of relapsing during the perinatal phase. Anxiety, people who've been diagnosed with anxiety disorders, there's a 20% of relapsing during the perinatal phase. And also, one thing that needs to be borne in mind, especially when you have mental health issues, or even if you haven't, 50% of pregnancies in the general population are unplanned. And this is relevant to know, because if you are on any kind of medication, then as a woman, you have to be aware of the potential impacts on your baby if you were to get pregnant during that phase. So it makes it quite important. And it's not just for mental health issues. And then why perinatal psychiatry is important. It's also the fact that this doesn't just affect the mother, but we're talking about affecting the whole family, the fetus, and obstetrics in general. So that makes it quite important. So looking at some common presentations, and just to kind of give an example, in the past, I've met this lady who, 22 years old, who had had her baby for just 2 days, presented as feeling very sad, could not cope, not confident about looking after the baby, was not eating, or was eating and managing to sleep. She had no history of mental illness. And with that, I'll be thinking of if somebody presented to me like that, and most of the time they present more to GP with these symptoms, that you'd be thinking of maternal blues, when the person doesn't feel able to cope, they are not confident in their own abilities. And it's very common. I think it's quite, some people suggest about 80% of women would suffer maternal blues. It can be quite scary if you have not had that experience before. You just had a baby, you've lost your confidence and everything. But just to reassure people, it's a very common presentation. Some people suggest about 80% of women will suffer with it after they've had their baby. But the important thing is that just most of the time, within 2 weeks or within a week, it should, if we are dealing with purely maternal blues, what we technically call maternal blues, it should have settled by then. And hopefully people find that reassuring. Most of the time, it's midwives who deal with it, or GPs who deal with such situations. So yes, as I was saying, about 60 to 80% of mothers will suffer it. And unfortunately, 20% can progress to what we would call clinical depression, or what most psychiatrists or even GPs would diagnose as depression. So talking about depression, for somebody to be diagnosed with perinatal depression, and when we talk about perinatal depression or postnatal depression, most of the time, as I said, we are looking at the first week of pregnancy to 9 months. But most of the time, people who have a diagnosis of depression already can still suffer it during their time of pregnancy, and we have to kind of bear that in mind. So somebody presenting with very low mood, hopelessness, poor sleep, feeling very withdrawn, not being able to enjoy anything, having difficulty looking after their baby, feeling that they are not bonding with their baby, feeling there's something. Sometimes people have a sense that there's something wrong, although it's not an objective view. They just have a sense that there's something wrong, and their behavior becomes quite different. And if these symptoms have lasted more than 2 weeks, then we'll be looking at what we call postnatal depression. And most of the time, these individuals are referred on to what we call by GPs to secondary mental health services. And most areas at present do have what we call perinatal services available. So then you would be seen by a perinatal mental health nurse. But these are some of the commonest symptoms that you present with. Postnatal depression, 1 in 10 women who have had their babies will suffer with postnatal depression, and can be between the first 2 to 8 weeks up to a year. And the symptoms, most of the time, to diagnose what we call clinical depression, the symptoms of low mood, poor motivation, not enjoying anything, should have lasted more than 2 weeks. And it can start, as I said, in pregnancy as well. And there can be the challenging bit with the postnatal depression in pregnancy or just after childbirth is that you can't. Poor sleep and poor appetite are common to any form of delivery. So it can be difficult if we don't necessarily focus on those symptoms. We focus on other symptoms when we're talking about perinatal depression. Another common, and just this touches on what we tend to call serious mental illnesses, and this puerperal, some places call it puerperal psychosis. You would be hearing of postnatal psychosis as well. And this is quite important to mention in the sense that most of the time the outcomes or the consequences are quite severe. So it would be an example I have is a 21-year-old lady who just had her baby for 3 weeks. Obviously, she found the baby that she was pregnant 5.5 months into the pregnancy. There was anxious build-up to the labor. She's now presenting as very angry, expressing concerns that the professionals who saw her, who did her labor, the midwives, were not good enough, challenging the authenticity of the midwife, saying she could do a better job, making statements like she's won the lottery, she needs to go off, she hasn't been sleeping at all, very talkative and suspicious when friends have been around, and very grandiose in terms of saying things that she has actually not qualified for. So such an individual, she was seen by the GP and she was referred to perinatal services. And her diagnosis was ultimately what we call puerperal psychosis, because she was presenting with symptoms that we deem as psychotic. And puerperal psychosis is quite important to recognize very early, because people, there have been several cases of women being so unwell that they end up killing their babies unintentionally. I have an example of a woman who felt suddenly within the first week of having the baby, felt the baby was possessed and ended up drowning the baby. And then obviously she was noted to be unwell. After her recovery, this is a situation that would live with her for the rest of her life. But she obviously did it while she was unwell. So quite important that we bear that in mind. The issue with perinatal psychosis or puerperal psychosis, that it happens very suddenly. I remember in medical school, one of the things that I observed that pushed my interest towards psychiatry was I was in the labor ward. We just delivered a woman of her baby. It was a very young woman, 18 years old. And within hours, she was all over the place, talking very loudly, laughing very inappropriately. She was naked and just running about very naked. And that is, unfortunately, a typical example of how puerperal psychosis tends to happen, how quickly it can happen within the first few weeks. People become very, very unwell. 1 in 5 women who have a diagnosis of bipolar affective disorder would have a relapse during their after they've had the delivery. And they said there is a 20-fold chance of having it during the first month after childbirth. And if you've had it before with your first pregnancy, most likely there's a 50 to 90% chance that you have it with your subsequent babies. And therefore it's quite important, if you have a family history, especially if you have mother or your maternal aunties who have suffered with this puerperal psychosis before, then you are at a greater chance of suffering such symptoms compared to the general population. So this is just for people to be mindful of and pick up when they notice anything different about a relative or somebody who's just had a baby. Do people have any questions as I go along? Or should I just?
Continue, there's none at the moment.
Okay, all right. So those are kind of obviously the commonest symptoms, but just like the general population, when it comes to maternal or perinatal psychiatry, issues of what we call personality disorders are still quite relevant, and it still affects us as just like it affects the general population. When you come to personality disorders, the individuals who are diagnosed with borderline personality disorders are the ones who tend to be quite challenging and come to the attention of services. But once again, there are appropriate interventions available to support people. Anxiety disorders is also very common. And I think anxiety disorders is one of the conditions that has worsened, and it has been noticeable, or there's documentation to support it has increased during the pandemic. And I think it's for obvious reasons. I think the whole general population have the anxiety levels heightened because of the pandemic, and to add pregnancy, being pregnant to it, and not knowing the circumstances of the whole situation, nobody knowing what's really going on, makes it even worse for a woman who is pregnant. So if you have those symptoms already and have mental health issues already, then it becomes quite difficult. But there has been support out there. The prenatal services have been quite active or proactive in supporting people. So anxiety disorders is definitely one of the symptoms that come up. Interestingly, within the context of the anxiety disorders, we have what we call OCDs, commonly known as OCD, the obsessive compulsive disorders. And I think there is an interesting connection with maybe having a baby and looking after the baby and thinking of cleanliness. There is some research to support that OCD symptoms tend to worsen when women have had their babies, but the treatment pathway is exactly the same for within any other circumstance. There's also postpartum PTSD, which is post-traumatic stress disorder, depending on how the labor went, or maybe circumstances around the pregnancy before labor. Some people can't develop PTSDs. And I think at present, the obstetric and gynecological services have a greater awareness of this and have input to support people. So just quickly touching on how we try to manage people or pregnant women who come to our attention, or women in general. We tend to work most perinatal services have available to them is what they call preconception counseling. And they recommended GPs and midwives to refer anybody who has a history of mental illness or a history of serious mental illnesses. And when we talk about serious mental illnesses, we're talking about schizophrenia, moderate to severe depression, bipolar affective disorder. When people have these specific symptoms or any other symptoms that they are not managing or coping with properly, even before pregnancy, they are advised to be referred onto perinatal services, and they provide what we call pre-counseling, preconception counseling. Because what is well noted with research is that 10 to 20% of pregnancies, unfortunately, spontaneously abort. And it's important to bear that in mind, because understandably, most women have apprehensions when it comes to taking medication during pregnancy, but sometimes it is important. And if you have the awareness that 10 to 20% of pregnancies will abort anyway, then it helps most women put things into perspective as to what risks they are prepared to take. 1 in 40 pregnancies, there is a risk of malformation just in the general population without medication, without anything. There's that nature base that you can have a malformation without anything at all happening or without taking any medication. And once again, in the same context, it's important that women bear that in mind. And there's also research to say that psychiatric illnesses alone, independent of any medication or anything, do cause some malformations in the system. Individuals who have, especially when you talk of schizophrenia, there is some research to say that there is an independent risk of malformation just because you have that condition. So once again, it's important to bear it in mind, especially when it comes down to medication. And what they also do is also discuss the risks and benefits, because most women with serious mental illnesses would be on medication already. And when you go and see the perinatal services for their pre-counseling, pre-conception counseling, what they try to do is discuss with you the risks and benefits. With some individuals, they have been on medication for years, and then the discussion would be during the pregnancy, if you're planning on getting pregnant, would there be a risk? Was the risk of you coming off the medication, and was the risk of you staying on the medication? Because at present, for obvious reasons, nobody can hand on heart say this medication can never do anything to your baby. This medication can never do anything to your fetus, because medications cannot be tested on pregnant women. So by virtue of that, no doctor can tell you that this medication is 100% free. Most of the time, what we are advised is based on the fact that, okay, this medication has been around for maybe 10 years or 20 years, and there isn't any evidence to say that it has caused this, or the evidence says it causes mild or manageable side effects or malformations, or doesn't at all. So then we can say, okay, compared to when if you are somebody who suffered with depression or schizophrenia and had severe symptoms, or you ended up maybe being naked on the street, or you ended up not eating and drinking for months, then the question would be, considering how you presented when you were unwell at that time, and if so considering that if you want to come off medication, and the fact that if you are on the medications they are taking now, there isn't any evidence to say it would affect your baby, then at least it gives a woman the chance to think it through, whether you want to stay, whether it would be in your circumstance. And it's quite an individual thing, because our mental illnesses, we might have the same diagnosis of schizophrenia, but our illnesses present quite differently. And therefore, based on how you presented the last time, do you think it's worth you staying on medication whilst you're still pregnant? So these are the discussions that they tend to have with us when we see the perinatal services specifically. But you can have that discussion with your GP as well. And ultimately, any professional, you see a nurse, a doctor, should tell you that it's ultimately your decision. I think what we're trying to do is to help you make an objective view, or make a decision based on relevant information. So that is what most of the time the pre-counseling services, preconception counseling would offer when you are referred to them. Well, for obvious reasons, most of the time, most women with any mental illness, or most women, specifically women who are pregnant or women who are breastfeeding, most of the time we try and look at what we call social management. So we're looking at psychologically what is commonly called talking therapy. So depending on what condition you have presented with, most of the time in the context of anxiety or depression, you would be directed towards psychological interventions. What the government has tried to put in place at present, I think nationwide, at least in England, I'm aware that we have what we call, it's short for IAPT, which stands for Improving Access to Psychological Interventions, and it is available everywhere, and GPs have access to refer you to them. Most places actually it's a self-referral process, so people who tend to suffer with maybe mild to moderate depression or anxiety symptoms are referred on to these services. And I know that in my area in the southwest of England, they tend to they actually have the perinatal women jump the queue. So if you have just had a baby, you are pregnant, they tend to offer urgent services for such individuals. So it is a good one to use. And those are when you see a psychiatrist or even GPs, what we tend to do is offer those first, depending on how your symptoms are. And I think there is a tendency that sometimes people feel that it's a lesser service, but it's really not. It's an appropriate service. And obviously we refer people depending on the needs at the time. And then we come to social management, which is relevant. And I think those, I do come from Ghana. Well, looking back home, I think most of the time we have input that is readily available to us. We have the extended family system is quite still relevant back home, and we have that. But sometimes when you come to England, sometimes being a migrant or even just living here, that family support can be quite limited. So that's when health visitors do come in, and they do have quite an extended service, and they do know where things are. So I think some places they have what we call sure start or home start. So these are what we would call social managements that are available, and health visitors, even midwives, some social services are aware of it and do readily refer people to it. So it's not always immediately medication. But obviously, once again, depending on your level of your symptoms, depending on the diagnosis as well, you might be referred on to what we call secondary psychiatry services, which would be the perinatal service, so sometimes just the general adult services. So some areas, the people who suffer with mild to moderate depression or anxiety, OCDs, would go to a general adult service. But people who have a history, women who have a history of schizophrenia, bipolar affective disorder, and other serious mental illnesses would go to the perinatal services, because they offer a more intensive input by virtue of people's diagnosis. So then ultimately we come down to medical management, what we call medication, really. We try as much as possible to avoid medications if we can, for the obvious reasons I kind of initially mentioned, but sometimes you can't avoid it. Sometimes the individual does need it, and sometimes the risks of not being on medication outweighs any benefits of being is quite large, that you just have to be on medication. Obviously, it's in discussion with you, depending on how well you are or how able you are to have that discussion. But we try to limit it to the minimal amount of medication. So sometimes some medications, you can maybe 20 milligrams of it would keep you well. With some people, they might need 60, but your psychiatrist would obviously keep you on 20 for a while to see if that will be effective. So we keep people on the least amount, the minimal effective. We try to, so the risks with medication, other risks with medication is that the more combination of medications you have, the higher the chances or the effects they can have on your feet or your baby, and therefore reducing, not having too many medications if you can have the same benefits of a medication. So there is a particular antidepressant that is called metazapine, for example. It helps with sleep as well, and then it helps with your depression as well. So if you are pregnant or you're breastfeeding and you need a medication and you have issues with your sleep as well, that would be a medication that a doctor would consider, because by giving you that medication, then we are taking care of your sleep and taking care of your depression as well. So that is what I mean by reducing polypharmacy. Sometimes within psychiatric services, individuals need injections. So individuals need monthly injections or 2-weekly injections. We try to not avoid that during pregnancy, because it's difficult to predict the accumulation in the system. So we try and avoid it as much as possible. If somebody has to be on it, then it has to be on it because of necessity, and there isn't any other options. I think I've touched on these, that the fact that there isn't any drugs that can we can guarantee that that wouldn't have an effect on your baby. So there's something called teratogenicity, and it's what is this teratogenicity is just referring to malformations, that the possibility that your baby would get malformed or there'll be a defect as they are being formed. And this is quite relevant in the what we call first trimester. So that's generally the first 3 months, that you try and reduce exposure to medications as much as possible within the first 3 months. And hence, that's why it's important that most women have that preconception counseling, so that at least you have that discussion of, so what tends to happen quite a lot is that when you think through with a woman the risks and benefits of being on medication, then you consider within the first 3 months, would it be safe enough for the woman to be off medication, because it is known that that is most malformations. If the baby is going to develop a malformation, it happens within that first 3 months. And that is why they're thinking we need to think about it. And that is why, going back to my very first statement about 50% of pregnancies being unplanned, and therefore any woman of childbearing age, no matter what medication, not necessarily mental health medication, any medication that you are going to be prescribed, everybody has to have the awareness of, what if I get pregnant? What will be the effects of it? And then you kind of think it through with the doctor or whoever is prescribing the medication. So the first 3 months is quite important. The second trimester and the third trimester, the 6 months and the 9 months, it is not really, you still have concerns there, but not as much as you would have within the first trimester. When it comes to the third trimester, the last month, what you'll be thinking of is some specific medications. They just after you've had birth, especially referring to lithium. I don't know if people have heard of lithium before, but lithium is a medication that we tend to fall under medication called the mood stabilizer. And women who suffer with bipolar affective disorder tend to have a bit. It's quite an effective medication, but it can, at the third trimester, because the body loses so much water, the levels of it can go up suddenly in the system, and it can be quite toxic and quite dangerous for the woman. And with those medications, that's when it comes to the third trimester, you have to think it through with your doctor what's going to happen. And I think most obstetric gynecologists have a good awareness of it. So it's just making your team aware of the medications that you're on, really. It can have, referring specifically to the lithium, it can have significant effects when people have it in the first trimester. So once again, it's something that you have to think through with your obstetric and gynecological team and with your perinatal services, what you want to do about that, if they would swap it with other medications, because I think it's one of the very important medications that by virtue of an individual being on it, it means your illness is quite serious, because it is one of these medications that is a tricky one in terms of getting it right. So it's something that we prescribe for very people who are quite serious in their illness. And so just touching quickly on, yes, is there any questions?
No, you can go ahead.
Okay, yes, so just quickly touching on antidepressants, just because it's quite the depression, 1 in 4 of us, that is within the general population, will suffer with depression. So it's quite, antidepressants are quite commonly known. And the commonest antidepressants that we have around within a group called SSRIs, we have sertraline, fluoxetine, paroxetine. They can cause what we call a pulmonary hypertension, but it's not very common. So one thing also we have to bear in mind is that although these medications some of them can cause some effects on the baby, when you think about it in percentage-wise, it might be helpful. And your perinatal services would mention it to you because it helps you put it in perspective. Sometimes some presentations or symptoms, some issues are noted because it has happened in an individual, and for legal reasons, they have to mention it. So you have to sometimes put it in perspective of the percentages or how realistically it's going to happen to you. And that's why it's also important when I mentioned at the beginning about thinking that 10 to quite a percentage of abortions or spontaneous abortions do happen. So if you think of it in that way, then maybe taking a risk of a medication that would help you and ultimately help with your baby, then it might help you put things in perspective. So if you have a relative that they are not, when they are unwell, are not able to look after themselves and thinking they are pregnant and are going to have a baby, if they do get unwell, you think about the consequences of not being able to look after the baby. That might be greater than the risk of taking the medication. So that these are kind of things I have to think about. So there are loads of these SSRIs are there. Most of them are quite have not been known to cause any bad effects on the fetus or the baby. So it's quite commonly prescribed, and some most GPs can start you on it if necessary. So there are quite a whole range of antidepressants that you can't be prescribed. So you might have, yes, pregnant and have mental health issues, but there's definitely help out there. That is what I'm trying to say. And then we have antipsychotics. Antipsychotics, most of the time, when we are thinking of antipsychotics, we are thinking about serious mental health issues such as schizophrenia, bipolar affective disorder. There's another one we call schizoaffective disorder, where the person is psychotic, and psychosis generally means the person is behaving unusually, out of keeping with their own selves. Sometimes we try and avoid going to specific symptoms because we are all individuals, and sometimes we have to be mindful and not tend to have the tendency of diagnosing people you meet on the street, or maybe you go to a relative's house, and if you don't know the person, then you have to be very careful because we are all individuals and we behave differently. And so you just have to, if the person their behavior is different from their baseline self, then maybe you start thinking, okay, this person might be unwell, this relative of mine or friend of mine might be unwell, maybe I need to take them to the GP. But if you haven't really met the person before, then you have to be careful and maybe not come across as being judgmental of their behavior. So if you know a relative who is generally very quiet and reserved, and then you go to their house and they're laughing off their head and being over familiar, then I guess you just have to start thinking, okay, this may be a bit unusual. So the psychosis just means unusual behavior. Their thinking process is not not in keeping with the general population. Or what also important when you think about psychosis is not in keeping with their cultural background, because some people have some behaviors that, if you consider that individual and their cultural background, it might be in keeping and not a psychotic phenomenon. But just kind of as an example, when you have somebody who comes from a very strong religious background and you meet them, as some people would know, maybe speaking in tongues, it would be something that when you take into perspective their background, their religious background, that would be normal. But when you take somebody who right from birth is an atheist, haven't even stepped in a church before, doesn't believe in God, and suddenly within a day or two suddenly have these very strong religious beliefs, then it might be kind of I'm sure the Christians amongst us will challenge me about that. It might be suddenly a hand of God in that, but it would be very unlikely. And with that individual, you have to think, okay, this might be dealing with psychosis. And that is when antipsychotics do come in. And
Dr. Maame, I'll just ask a few questions. I think that
yes.
the majority of people on this call are lay people. So whilst it's really interesting,
yes.
I think one of the things that I like to have for people is sort of a general message that they can take home. And for the examples, so lots of the examples that we've talked about will be people that we expect to be having some support from their own psychiatrist or their GP, in a sense, I'd expect, yeah. So one of the things I want to talk about was mainly just maybe a message about medication in pregnancy, because for most pregnant women, as soon as you get pregnant, what you've heard throughout your life is, please don't take any medication. But one of the things that we probably need to emphasize is that in some cases it's necessary for your own health, isn't it? I think that probably plays into the pandemic and the COVID vaccine. Because all through our lives, we've heard as a woman that once you get pregnant, please avoid medication because we don't know the impacts on your baby. And here we are now saying that actually it's quite important to have medication and the vaccine. And I think the other thing that's a bit of a challenge is that the advice has changed throughout the pandemic. So it started off at the beginning with saying, pregnant women, we don't have enough information, don't take the vaccine. And then it was saying, well, take it if you want to. And now it's saying, oh, please, definitely take it, because we've seen more and more pregnant women who are quite unwell with COVID. And so the information now is that you should actually take the vaccine. But the other thing I wanted to ask you about in terms of health of women when they're pregnant is the role of partners. So we've really emphasized on the role of health professionals. What role do you think that partners have to play in this?
Definitely a very big role, and a very big role, especially in our current community where it's more of a nuclear family. So right from the start of the pregnancies, I think most obstetric and gynecological services do, well, with the exception of, I think the whole pandemic has messed things up, but they do, which usually encourage partners to attend all the perinatal meetings with them, because it's important, because there are a lot of hormonal changes, there are a lot of changes going on. So it is definitely important that partners are aware of the process or the progress of the pregnancies and how to support individuals. I think it just comes down to the very individual and the partner knowing themselves and how to support them. So I think it's difficult saying, but I mean, when you come to mental health specifically, you would like to think that if the individual has pre-existing mental health issues already before the pregnancy, you would like to think that the partner has always been involved in it. But then if that is not the case, and maybe they have become unwell during the pregnancy, then it's quite important. I think most GPs would accept a referral would take a feedback or a referral from partners. So if partners do have concerns, it's important they ring in, because it would be taken. I know most GPs would take that into consideration. They would obviously want to speak to the woman involved, but if that is not possible, or they are unwell so much that they can't give consent, then most of the time that is when it comes down in the direction of the secondary mental health services. But partners.
Okay, so one of the things that we will say is that if you as a partner or you have anyone who you're concerned about, please ring into services if you're concerned. And what's the percentage? What would you say is the percentage of people who have because obviously amongst your service you've got people with pre-existing mental health problems who then get pregnant, but then you've got people who are pregnant who have had no pre-existing mental health conditions, and because of the pregnancy they become unwell. So what percentage of people do you see with that? Is that very uncommon? How common is that?
It's quite common. I think the commonest one would be depression, because by virtue of the fact that 1 in 4 of the general population do suffer with depression, when you come to pregnancy per se, with all the hormonal changes, the stress of the pregnancy itself, and the social issues that come with being pregnant as well, quite a percentage of women do suffer with depression. Most of the time, maybe not to the extent that we would definitely diagnose what we call clinical depression, not that severe, but most women tend to have issues with anxiety, or as I mentioned in the beginning, the baby blues do happen quite frequently in about 80% of women who have not. So the baby blues is actually not in women who, the 80% is not women who have who've had mental health issues, but we're talking about the general population of pregnant women. So baby blues per se is like 80% of women do suffer with baby blues.
So, if you have 10 women who've just had a baby, 8 of them will have some baby blues. But how many of them will just get through that with support from a partner and from their environment? Because I doubt that you're seeing 8 out of 10 women who've just had a baby.
About 6 of them would recover with family support. That is why I was putting emphasis on the family support. About 6% would suffer. 6 out of that would recover with just family support and the social support and the psychological support. So
that means that there's another, so 2 out of 10 would come to your service?
Yes, 2 out of 10 will come to our service.
So that 2 out of 10, so 2 out of 10 might go to the GP. Is it then even less than that would actually come and see a psychiatrist?
To secondary services, exactly, yes.
Okay.
Yes.
So for people out there who feel the baby blues, what we're saying is that it's really common, but most of the time what you need, and for people out there who have partners, what they need is support from you and from mums and aunties, because it can be quite a stressful time for anybody who's had a baby. So the information today is, if you see a change in behavior, that doesn't stop you from trying to support your partner or signposting to the right environment. And if you've just had a baby, everybody knows that you need to bring out all the stops. You need to do everything you can to support people who have, because it can be a stressful time. And that's great. Now, the baby blues is normal, isn't it?
Yes.
It's common,
it is.
as you said.
It is.
The 2 out of 10 that tend to need referral to secondary services, is this just to do with pregnancy, or is there usually an underlying mental health illness that has not been diagnosed?
The baby blues base, it could be just women who have no history of mental health issues, have not necessarily been diagnosed with a mental health issue before, but then the pregnancy, the hormonal changes, their family circumstances has pushed it on to depression. So when you're out of that baby blues, those 2 people will be looking at what we call clinical depression. So there could be quite a lot of social factors, sometimes issues with work, just because they are pregnant. Unfortunately, some people would end up losing their work. And one thing maybe I have to emphasize, that the pregnancy itself is known to put a lot of constraint on relationships. So it can be quite difficult just by the mere fact that people are pregnant. Because if you think of it, that 50% of pregnancies are unplanned, then it comes as a surprise to the pregnant woman herself and the partner. And most likely they are at a stage in their life that they are not necessarily prepared for. So it becomes quite complicated. So dealing with those emotions of a certain pregnancy all throughout the process, and the changes that happen, it's quite a life-changing, it is a life-changing thing. So those are things that can be quite challenging for the pregnant women, and definitely for their partners. And it's a matter of thinking it through, really.
Tend to see any difference in, I know you work in, where is it now, Avon and Wiltshire, isn't it? So it's not a very diverse population, but in general, within maternal medicine and psychiatry, is there is there diversity in it? Do you see lots more Black people presenting with problems, or is it that has no impact at all?
I have not seen anything out of the ordinary that Black women are presenting more. If anything, I would like to think that the family support system that we have, or how we deal with the extended family system, is quite protective. So you would find that even if you just sticking with just baby blues, actually very few women of diverse background would present to their GPs with baby blues, because most of the time families tend to deal with it, because most of the time they are not isolated. So they would have families around them, or they would have a friend around them. So that in that sense, we are protected in that sense. So what we would tend to have is more of the serious mental illnesses, but with the perinatal. So we are not presenting, people of diverse background are not presenting any worse than the general population, as far as I'm aware of.
And has COVID made any impact? Has it made it worse? You see more referrals with the current pandemic?
Referrals to psychiatry in general has increased a bit, and it's more in the context of, as I mentioned initially, the anxieties around the whole people not knowing, and also what is trickling down. I think what the effect we are getting now is that some individuals have done well to contain their anxieties for so long, and now it's spilling over because you're thinking, okay, it's for a few months, but then because it's dragged on for so long, what we tend having now is people presenting with more serious illnesses, because pre-pandemic you would catch them early. They would seek input from their GPs early, or they would seek input from their care coordinators early. But because of the pandemic, people have been staying at home as rightly they are supposed to, and not seeking help, or not feeling necessary to seek help when they have to. And therefore we see the extreme end of things, that then people have become so unwell. It's rather others who are picking up on it. So that is what we're having now.
Is the pandemic now affecting the number of inpatient beds you have? Do you have less availability, or it's not?
Yeah, it's an inpatient bed in the general population. For general adult, it is quite a dire situation. We send them people right up north because there isn't anything down south. It's very interesting. It's a very interesting situation because it's a combination of systems, which has happened that way, and people being unwell as well. So the change of the bed system because of the pandemic has had an effect, and then people being unwell as well has had an effect. But one positive thing that the pandemic did right at the beginning was that we had people, because we are all not running around so much, you realize that people had a family at home, and that was actually very helpful at the beginning. People were talking to each other. So most of the time, people are running around being so busy that people have nobody to talk to. So you refer them to a professional to talk to them. You read that at the beginning of the pandemic, families were staying closer, and that did help. So it's had its good size, but now
so the need for psychology services went down because people were chatting with each other. But it meant that if you needed a psychiatrist, there were more people who required that in a sense, and so that's put a bit of pressure on your system and your service.
It definitely has. It definitely has, and it's been dealing with very serious illnesses as well.
Okay. I suppose as psychiatrists, have you tended to use more of things like this, video conferencing for your clinics? Because very often you don't need to do an examination per se, do you?
So we've been trying to, right at the beginning of the pandemic, we're doing more of the video conferencing, but at present we are trying to do a mixture of both, because depending on the individual's presentation or their concern, especially most people with a serious mental illness are very uncomfortable doing video conferencing. And it's like, if you think of somebody with paranoia, doing video conferencing, it does not work well at all. So we have to take a measure of what the GP's concern are at the time of presentation to decide whether to offer them a video conference. Some people are very comfortable with it, but some people do not like it at all, and it just provokes anxiety in the individual. So it has been a measured thing. So depending on the individual, we do offer video conferencing, but we have been offering face-to-face throughout as well.
Okay, that's interesting, because in actual fact, for many services, things have been modified quite a bit because of the impact of the pandemic, where you can now offer different ways in meeting people to try and reduce the burden on our face-to-face services. So that's really interesting. Well, thank you so much. I haven't had any further questions through the chat, and sometimes we have questions from, oh, here we are, we've got a question here. So there's a question here about asking about how important the GP postnatal check is, because we know that at that postnatal check that GPs will assess mental well-being, and the well-being they assess, do you think there's any sort of cultural aspects of this? Because some Black women will say that that element is sort of left out in their cases in preference of physical checks and questions. So they'll come and do the 6-week check, they will do the physical check and make sure okay, but because they're not as conversant with things that affect the well-being of Black women, it's felt that in some cases that is missed out. Have you got experience of that?
I don't have a direct experience, but I can see that happening. I think generally GPs do not really do well with picking up mental health issues. So I think when you are from a diverse background, then it becomes a tricky one as well. But what I am aware of is that when you do bring it up, I think they tend to respond to it. So if you there are issues, ongoing issues that you want to discuss, I think they do tend to attend to it, but I'm not sure if they are necessarily proactive in asking about it. If anything, I think maybe the midwives are better at picking up issues with mental health, well-being and all that better. The health the midwives and the health visitors might be in a better position to pick up those things. But also, I think the GPs, if you do bring them up, they do acknowledge it, because I'm assuming that they tend to think that the midwives would have dealt with those issues.
But even if it's midwives or doctors, do you know whether there's a set of standardized questions that they ask to find out if there are issues?
They definitely are. They definitely have screening tools that they are supposed to use. I do remember
screening tools that I'm asking about, because one of the things I discovered was that some of the screening questions that they have about dementia, for example, they might ask older people about what happened in the war. Now, we now have an aging population who are migrants, who have never watched, who were not here during the war, or have never watched some of the TV programs I might refer to that everybody seems to know about, but they weren't here at that time when they were younger. And these are the screening tools they were using. And so because you couldn't answer the question on, what was Hitler doing, then you might be put in the dementia category, where in actual fact, it's just because you don't know about LOLO, the TV program, because you just weren't here.
Yeah. That is definitely, I remember when I was training, I did older adult psychiatry, and definitely one of the tools that we use, I think it asks you about, there are a few questions that were kind of culturally, if you didn't grow up in England, you wouldn't be able to answer. So that is definitely an issue. But I remember that had been picked up on, and what they were trying to do was to adjust the questionnaires. I'm not aware, I haven't seen what the adjustments they've made, but I am aware that what is very clear is that all the screening tools, you have the mini mental state examination. I think what you are referring to is what we call the ACE-R. They try to, you have to name, make a statement about their person's cultural background and also their person's level of education. So there are things there that have to be, there are questions there that have to be answered, and then subsequently they make modifications to it. But I am aware, at least, that at the time I was training, that is something that had been noted, and we're going to do something about it, but I haven't really done older adult psychiatry for a while. So in reference to that specific dementia screening, I can't be specific, but I think that increasingly the awareness is there, and they are picking up on some questions are definitely culturally inappropriate to ask. So I think that is a first step. At least the awareness is there, and they are taking steps to address it.
I think the other thing that we worry about quite a lot is medication, and I know that it's when it's relevant and necessary, then obviously we have to use it. There's a question here asking that, do we think that GPs and psychiatrists take into account your social background and the support you have before starting people on medications? I suppose I think the relevance is medication, one reassurance that it's not the first route of that is taken.
Yes, I think any psychiatrists worth their salt will tell you the medication. And that's why I tried to point out during my presentation when I mentioned about the psychological. If you noted, I mentioned the psychological interventions and the social interventions first. We try to keep medications as a last resort, really. And most of the time we encourage people to have done with the talking therapy first and looked at social measures first. So most of the time, especially when you come to serious mental illnesses, medication is quite relevant. There are some illnesses like maybe mild to moderate depression that talking therapy is known, that talking therapy on its own or individuals' change of circumstances do help with that. But unfortunately, there are some illnesses such as schizophrenia, bipolar affective disorder, schizoaffective disorder. If you have those diagnoses, there isn't the social and psychological aspects are not alone, are not enough to help manage it, and it's quite important. And I definitely know that I take people's living situations into consideration, their work situations into consideration, and that because I think we do that, and we have the privilege of doing that because we have a variety. Fortunately, at present, we have a variety of medications that allow us to have that discussion. So kind of the example I gave about the medication called metazepine, obviously you wouldn't prescribe it for somebody who maybe operates with machines or does other things, but there are loads of other antidepressants that you could definitely use. So it is definitely something that we do. Any good psychiatrist should have that discussion with you. There are medications, like even when it comes to antipsychotics, there are medications that most of our medications cause weight gain. But fortunately now we have a medication that does not cause weight gain. So, but then it also depends on the severity of your illness, because there's some medications are very slow in acting, but some medications are also very quick. So definitely it's something that please feel free to have that discussion. And I think most psychiatrists would prefer to have that discussion rather than kind of just tell you this is what it is. They would rather put in front of you, this is what is available and what do you think? And that's what we are encouraged to do. And I know that's what I actively do in my practice.
And lastly, I'm just going to ask a question about spirituality and whether, when you're considering how you manage women who present to your services, whether you consider spirituality and emotional well-being when you're discussing treatment options, or how you care for these women when they present to you, because that's really important in our community.
It is very important, and I think that is something well acknowledged. And I remember, I think the Royal College of Psychiatry actually had a spiritual faculty, religious faculty that dealt with. So it's something that is well acknowledged. And I think there is some research to say that people with a religious background, that it is a protective factor for them. So it's something that we tend to have that discussion about. It can be a bit controversial or difficult when you come to the management of some specific conditions. And that is where I was just trying to point out the fact about people's cultural background and how some of these kind of religious things can be an influence. So yes, definitely it's something that we note that it is helpful to have that spiritual background, and it definitely helps with the emotional well-being of people. But with very few individuals, there can be some hindrances that comes with seeking interventions because of people's religious background. So largely, it's something that is well encouraged, and it's something that we would, at present, I know that my ward, they would ask you about your religious background and if you want a priest or somebody to come in. So it's something that is being actively worked on. But with very few situations, it can be quite a difficult discussion to have.
Well, thank you for your time this morning. I think it's been really eye-opening, and I think the messages I would hope that we take from this today, because we're always really keen that people who are watching or log in take a message. And one of the things that we'd like to emphasize is that we need to look after ourselves. I know this is a perinatal mental health session, but in actual fact, all of us need to be looking after our mental health now, because it's a difficult situation. And as Dr. Maame has pointed out, psychiatric beds are overwhelmed at the moment with people suffering from lots of different issues. Really, for pregnant women, we need to be really supportive of them as well, just during the pregnancy as well as after the pregnancy, because it can be a vulnerable time for women. But that if you notice a change in your partner's behavior, first of all, I think the biggest message is supporting your partner. So you support your partner, and also make sure you're getting help from the wider family, because it's a really difficult time when you've just had a baby. I can speak from personal experience, as many women here can, about wanting to do your best, but suddenly having somebody else that you need to look after as well, and all other things as well. So making sure we have that protective ring around our women who are pregnant, as well as just after the pregnancy, and supporting them any way we can. And especially at a time like this, where they've had mixed messages throughout their pregnancy, start with to do with the COVID vaccine and things. And we need to help them to be able to access good information to make good choices for themselves and to look after themselves as well. So thank you so much for this session.
Can I just say a word that psychiatric services are very open and non-judgmental, and we, as of diverse backgrounds, should reach out, just have that discussion, really. All you need to, because I think sometimes we leave things for too late. We just need to reach out, have a discussion, ask a question, really. I think we prefer that is what we encourage people to do. Ask a question, see your GP, ask to be referred on if necessary, and they tend to. And please, there is a lot of support out there professionally, and in all aspects. Just ask a question, and we are really always ready to help.
And I think that's a really good final message, because there is a stigma of mental health, and what we want is for people to sort of access services that are there to help. There shouldn't be a stigma, especially if there can be support that is given. And even if it's just advice and being taken, I think that's the final message today. So thank you so much for your time, and thank you for those of us that have joined us. I'm going to hand over to Elizabeth now to just tell us what we've got for next week. Because we, as you know, for those of you that join us on a regular basis, we have a number of health sessions throughout the week, and we'll be here next week as well. So Elizabeth.
Hi everyone. Thank you so much for that, Dr. Maame, and thank you so much for that, Dr. Ngozi. Thank you for those that are also tuning in with us on YouTube and on Facebook. Yes, like Dr. Ngozi said, we'll be back again next week, Saturday, from the same time, from 11 a.m. again till 12:30. So please do tune in with us. I believe next week we'll be focused on chronic illness. So please do tune in with us, and send in your questions as well ahead of time, as well as on the session itself. We'll also be tuned in on Tuesday as well, next week Tuesday, from 6 till 7 p.m. for our CAHN Healthy Hearts. So feel free to tune in with us as well. We'll be having a boxercise activity, and we'll also be having our nutritionists and dietitians come and teach us as well. So please do tune us with that, and we look forward to seeing you at some of our upcoming events. Over to you, Ngozi.
Well, thank you very much, everybody, and have a nice Saturday, and I'll see you next week. Bye.
Thank you. Bye.